there's very few disorders out there for which there's so many exciting therapies coming along so quickly. And so, I think that there are at least 3 or 4 compounds close enough to development that hopefully they'll come to clinical trial within the next 5 years, which I think is an astounding testament to the success of the entire SMA research community and the families.
To have so many, you mean?
To have so many, and not all of these there'll probably be glitches along the way. There's going to be reasons why they might fail in safety trials in some instances, but the fact that we are at least highly likely to have a new, some new entities coming available for clinical trial that really show efficacy in the animal models is very exciting.
It really is. Where do you sit on the question of universal screening, and would you like to see it applied across the country?
So I've been very interested in trying to promote newborn screening for SMA, and one of the reasons for that is because many of these therapies in the animal models show better efficacy the earlier you can give them. And I think if we could also treat our children as early as possible, that might make the difference between an effective treatment versus a cure. And I think that newborn screening has come a long way for many disorders. And this is the theme over and over again, that if you can get even effective therapies as early as possible, particularly in SMA, where you know that motor neuron loss is occurring early, then that gives us the best chance for a cure. And that's my ultimate goal. Is I would love to see a cure. I would also, in the interim, love to see my kids get stronger who are already weak, but for newly diagnosed families to be able to have effective treatments that could even have that much better of an outcome is, to me, a very important objective.
To prolong life, or to make
to not only improve quality of life for all the kids out there, but to also effectively treat them at the earliest possible opportunity. And in order to do that, there are lots of different things that we have to get in place, because one of the biggest problems that we have for clinical trials right now in SMA is that the outcome measures require the kids to be of a certain age to cooperate. And so, again, you miss that window of opportunity right now when children may be presenting at, say, age 1 year old with type 2 SMA, but they won't be eligible even for these new compounds for clinical trials, because we don't have the outcome measures for that age group at this time that are accepted by the FDA. And so I want to pick the groups of patients to study these compounds or these new therapies with the best possible chance that they'll move forward. One of the risks that you run into with clinical trials of compounds that might be effective if you include patients who are very, very weak is that you might not be able to prove it in the clinical trial that it's effective for some children, because you included other children who may not have been able to benefit. And because of the tremendous investment that goes into these drug companies, they have a very low threshold for throwing away something after 1 or 2 failed clinical trials. So unless we're extremely smart about how we choose to do these clinical trials, we risk taking what might be effective therapies across the board to some degree for all children with SMA and missing that opportunity to bring them forward. I don't want to see that opportunity lost. That's a really important issue for me. We need to go back and really focus on looking at nutritional interventions and looking at respiratory interventions in terms of improving the lives of our children. And this is because they clearly have such a big impact in outcomes. And we can see that effect when we look at some of the clinical trial data that we've done so far, where centers who perhaps have more developed protocols for intervening early for nutritional respiratory deficiency or for respiratory support are looking like they have better outcomes in some instances for the children. Now, there are people who have said, well, of course, prolonging survival isn't the most important thing. We also have to improve quality of life. And so I think nutrition and respiratory support is critical to that, because we really want to keep them as highly functioning as possible. And so the whole field has really changed with we as clinicians being very reactive in our approach, waiting until our children present with a problem before we address it, to trying to think of new ways to be more proactive and figure out protocols that we can implement in the clinic setting that will make a long-term impact before the children get hospitalized with a complication.
Is it either or typically? I mean, that's
obviously
the reality often is.
I think the reality right now is that it's mostly still reactive, unless it's really driven very much by the parents because of our medical care system in general. Our medical care system in the United States is not geared towards preventive care or proactive care. We are a reactive care society. And I think that needs to change across the board, not just for children with SMA and neuromuscular disease, and not just for any other neurodegenerative disorder, but for heart disease, for all of these other issues that we run into in our healthcare system. And I think a good model where this has been incredibly effective is the cystic fibrosis model, where they are now picked up on newborn screening in the majority of cases, and they very quickly are put on proactive respiratory care regimens, proactive dietary and supplement regimens, which have made a huge impact in survival and quality of life in that population. And just to give you some perspective on this, compared to 30 years ago, survival, has improved at least fourfold, from very common death in childhood to virtually all of those patients, or a majority of those patients, living well into their third and fourth decades. So that just shows you a testament, and there is not an effective therapy. There's not a cure for cystic fibrosis. This is all nutritional, early treatment of infections, aggressive respiratory therapy, all of those things that we need to get in place for our neuromuscular population, not just SMA, but kids with Duchenne, with other neuromuscular disorders as well.
Either drugs or an alternative, or is there room for both?
I think there's room for both. And I think for clinical trials, it's important that we try to standardize our care as much as possible so that we can show the effect of a drug in conjunction with what we're already doing with diet and nutrition. Because some of the animal model data has shown that you can have a certain degree of benefit with a drug, and then if you add nutritional intervention with that, you can get a very significant increase in benefit. And Dr. Sumner can talk a little bit about some of her work in the animal models with that, with regard to that issue. I think that the toughest group is going to be the children with SMA type 1. And again, my bias is that we need to identify those children as early as possible because there's such a short window of opportunity that the degree of intervention sometimes is so difficult for parents. It's really overwhelming. And so we don't want to end up in a situation where we prolong everyone's life at the expense of quality of life. We need to intervene as early as possible to have the chance to improve the outcomes overall, not just for living longer, but living better.